Welcome to this live webcast in New York City. The webcast is entitled Advances in Minimal Residual Disease Testing in Myeloma, and we are here at Memorial Sloan Kettering. On my left, I have Dr. Susanne Lensch from Columbia University. Welcome.
Thank you for having me.
On my right, I have Dr. Sundar Jagannath from Mount Sinai. Welcome.
Thank you for having me too.
It's a great pleasure having both of you here. We have had a long day with a lot of discussions on minimal residual disease testing in multiple myeloma, and I think we had 70 people coming from across the country and also from Europe. We have representatives from academia, from many drug companies, and also we had the FDA here. So during this webcast, we decided to discuss minimal residual disease testing in three particular directions. One, in the direction of MRD as an endpoint for drug approval. The second one is MRD as a tool to use in the standard of care setting. And the third, to use MRD when we write new clinical trials for trial design. And these are the type of questions we have asked people during the day. And we did 3 short videos. So let's look at one of those videos. Let's start with the first video on MRD as a regulatory endpoint, and then we discuss it afterwards.
I'm not sure it's ready for prime time as a regulatory endpoint. We would definitely need more prospective results and clinical data to fully assess the value of MRD testing at this time.
So I believe that we have enough data to go to the FDA and to discuss with them about which tests have the best sensitivity and what the best approach is to move forward.
I think it's a good idea, but I think we're not there yet at the moment.
My answer is definitely yes. We just got last week the results of the IFM DFCI trial looking at MRD by NGS and really going to 10 to minus 6 MRD, you have a very, very different outcome in the patient, even in patient in CR. So definitely I think the answer is yes, yes, and yes.
So I think I heard many yeses in the end. Dr. Hervé had, I think, 3 or 4 yeses himself, but also a couple of no's. So what's your thinking, Susanne? MRD as an endpoint for regulatory approval in multiple myeloma?
I personally think that MRD is very important, and I include that in my investigator-initiated clinical trials because I think we have to really explore the importance of this measurement and of this biotool. But to use it right now as a regulatory endpoint, I think it's too early because there are several problems. We need to define MRD measurements. As I pointed out today, when we measure MRD, we talk about 4 different methods. It's allele-specific oligonucleotide, PCR, it's flow cytometry, and it's next-generation sequencing. So we have different methods, and to compare those different methods is very difficult. So having said this, we all agree also that flow cytometry probably is the most advanced and most common used tool to measure MRD. But even to measure MRD by flow cytometry is associated with a lot of heterogeneity in different, I would say, institutions. So not each institution has established really the Euroflow, for instance, what is the standard of care. So I think it is very difficult to implement this tool because we don't have a standard how to measure this. This is the biggest problem right now.
Sundar, what do you think?
Well, using the standard endpoints such as overall survival, now especially for myeloma, that is becoming too long to wait to get a new drug approved. Then we went to progression-free survival. This is also, if you move it in the upfront setting, it is pretty long. So we should look for surrogate marker, and then MRD is an excellent surrogate marker at a certain time. Of course, we have to come to a consensus which is the best. It looked like in this meeting, it was a lively meeting that you had organized, and I found like 10 to the minus 5 was a good surrogate marker. How we define it with which methodology, but if we all agree on that kind of a marker, I think it can move forward and it'll move the field forward because we do need a mechanism for accelerated approval of drugs sooner. And for that, I think MRD is a good measure.
Yeah, so I think my take from the discussions, I agree with both of you. I agree with what you said, Susanne, that it's difficult. There are very many methods. But I think also what I heard the FDA saying today is that it may not matter what method you use. It's more a matter of sensitivity. So if you can deliver negativity with a defined degree of sensitivity, that's good enough. That's what they have done in other diseases, in chronic myeloid leukemia, and they are working on CLL, chronic lymphocytic leukemia. So I think that the FDA sounded quite positive that they could consider using it. And I agree with you, Sundar, that we cannot wait for overall survival. That's going to take very, very long. Even progression-free survival takes many years. Beyond that, looking at the new drugs, most patients actually reach a complete response, and they have a fantastic response. We really need a more sensitive tool. So MRD seems to be the only logical step from where we are right now. We really need a better tool. So if we could put all these pieces together and agree, and the FDA would agree, then we would be able to develop drugs faster. That would be my take.
Yeah, I completely agree.
But Ola, until then, it's kind of, we have a little bit of work to do, because I think the FDA would probably not allow to compare PCR with flow cytometry and flow cytometry in different methods. I think what we really need to do is to, and you mentioned that today, to find, the standard. What kind of flow method do we do? Is it feasible at the institutions, especially for larger trials? And I think I want to mention the Spanish initiative here, the Euroflow. The Spanish group with Bruno Paivac did really a good job to establish, to validate, to test the Euroflow on many, many samples and on a large number of patients. And I think they are kind of, most advanced in their measurements. So our job is it to bring his method, or the Spanish method, I think, for instance, to the United States and use it in many academic centers in order to make our test really comparable. And I think this is really critical for the regulatory, to use MRD as a regulatory endpoint.
Right. Yeah, so the first part of this discussion now, what we try to hone on is really the regulatory aspect. We will come back and talk about the clinical care, the standard care, and also when we write protocols. So I agree with you, and of course we can all have different opinions. That's the meaning of this discussion. I think my take is that if we can, as a group, come up with a proposal and go to the FDA, I think I heard today that the FDA would be willing to work with us. But if we have not come up with one message, it's going to be hard to work with them, because they don't want to hear different methods from different groups. So correct. I think that's the homework that we need to do as representatives of academia, and the drug companies, I think, also said that.
No, I think it was a lively discussion here, and we also had MMRF sponsor that. So, patient advocacy group is also interested how to bring new medications for the treatment of myeloma patient. So I think, it was good that you organized this lovely meeting, because I think we need to move forward in this area to agree upon a surrogate, MRD as a surrogate for PFS, so that we can have accelerated approval pathway. I think, that's why I'm really excited about it.
Yeah, and I think to point out Sundar's point, I think indeed overall survival is something we cannot wait. To assess overall survival in clinical trials is more and more difficult, because patients go through many, many trials, and to really pinpoint what was maybe the effect on the first trial, the patient went through, or the first treatment, is really difficult. So that's why, in addition to PFS, or instead of PFS, MRD negativity might be a time point we can assess earlier to see the efficacy of the drug.
Right. And to kind of add to the complexity you were bringing up, I of course agree that there is more work to be done before we can nail down how we want to do it. I think beyond the methods also, when exactly should MRD be evaluated? Is it at the time point of complete response? Is it at 100 days after an autologous stem cell transplant? Do you need to have more than one measurement to make sure that MRD was captured twice, for example, 3 months apart? Those are details that I think we definitely need to go back home and work on, and then come back to the FDA.
I agree.
Beyond just which method to use or which sensitivity level to use.
Right.
Do you agree with that?
No, I agree. I think this is a good way to look at. Here I looked, Antonio Palumbo's presentation was interesting in this regard. He showed that it takes now 9 months to get a patient, the induction phase, and if you're going for the MRD negativity, it at least takes 18 months to follow the patient. So there are a lot of leads, positive leads.
I agree. I think that was a very interesting presentation about MRD being an early marker of relapse. And that actually takes me to the next point. So the next video is to look to see what people thought about using MRD in all patients who obtain a complete response. Let's look at the next video.
At this point in time, I think MRD testing should be offered to any patient who's enrolled on a clinical trial and achieves CR. The main emphasis in research right now is to develop standardization of MRD testing. Once that is done, I think it should be offered to all patients who achieve CR in clinical practice.
So I don't think it's ready for standard of care just as yet, and I think we need to do the studies prospectively. I think the good news is we know that MRD can be applied. We know that it translates into an improved progression-free survival and an overall survival. What we don't know, though, is how do we follow these patients, and does this test actually meaningfully contribute to treatment decisions? And for those reasons, I think we need to do those studies before we can start applying it to anybody and everybody.
I think MRD has been shown in a number of studies to predict outcome. Those who get MRD negativity do better, survival-wise. And I think it should be offered to every patient in the research and clinical setting so that we can prognosticate better and actually tailor our treatment appropriately.
Absolutely. The data is strong, it's overwhelming, and it provides additional prognostic information which we can pass on to our patients.
MRD testing is very exciting, but at the moment, I don't think that it should be recommended for every single myeloma patient in the world in CR. And the reason is that it is not really standardized. It's very costly and time-consuming. So if you get to choose in a lot of countries, you don't have unlimited amount of money. If you get to choose best available treatment or MRD testing, then of course you should go with best available treatment.
These were another set of interesting opinions and reflections here. So Sundar, what's your thinking?
In this regard, I have to agree with what the naysayers like Nupur Raji and Christensen. Doing MRD in every patient, there is some prognostic value, but even there, if a patient who is MRD negative, say, 3 months after transplant, need not be MRD negative 3 years from transplantation. The value of MRD negativity 3 years after transplantation may be more valuable. Moreover, at the bedside, suppose I found somebody who is a MRD negative CR or somebody is MRD positive complete remission. Their quality of life is good. I don't want to give more intensive therapy for them to make MRD positive CR into MRD negative. So clinical ramification is absolutely not there. I can understand as a regulatory for drug approval purposes, checking it out is important. But a day-to-day management of care, I don't think this is a prime time at all.
Susanne?
Yeah, I completely agree. I think for standard of care for the daily practice, it is too early. It might be confusing for patients, and it might be very labor-intensive and expensive for the patients, for the general practitioner. Again, we don't have even standardized the test. So what should we recommend? Should the hematologist request a PCR or flow cytometry, next generation sequencing? I think that's very confusing at the moment and not very helpful for the patient, because the MRD positivity would not really guide us in our treatment, or MRD negativity. I think it would more confuse the patients instead of being helpful. So I think for the daily standard, it is probably too early to use MRD testing.
Okay, so I'm going to be of the other opinion than the two of you.
Good.
And again, that's why we are here. So I've been thinking about this a lot, and I have done a lot of trials where I have implemented MRD in clinical trials, and seeing that you have a difference in progression-free survival in those trials and also overall survival had made me wonder, why don't I offer all the patients this test when I can do it? So we have set up the flow cytometry test, and we have the sequencing-based test, and we do offer it for all patients that reach a complete response. At the same time, I have to agree with you that I do not know if someone goes from MRD negative to MRD positive, what that really, really means.
Mm-hmm.
But the reason I do it is because I want to learn. And if we don't start doing new things, there won't be any new evolution and new development. So that's where I am.
Yeah, that's completely right. But we learn, especially from clinical trials, because only data from clinical trials we can capture and we can correlate with outcome. It's really difficult to capture data from our daily practice or from our standard of care. So that's number one. Number two is, I think we have to be careful working in an academic center. What do we recommend for the general oncologist, hematologist? Implementing flow cytometry and MRD testing at Memorial Sloan Kettering or Columbia University or Mount Sinai might be easy and feasible, but it might be more difficult for smaller hospitals to do that. So we might put pressure on smaller practices to do something. They don't know exactly whether that is of any value for the patient immediately, and we don't know what is the quality of the test. So that's why I completely agree. In academic centers, we are interested, and we probably do this, but we have to be careful to really recommend that for everybody who is getting treated for multiple myeloma.
That's my take also. I'm not want to recommend every outside doctor in private practice to start doing it, because as you point out, it takes a lot of resources, it's expensive, and you need to have a lot of expertise and infrastructure to do it. You need to do it right, otherwise you're going to have false negative results that are meaningless. But I do think beyond trials, what we have seen is that patients who reach minimal residual disease negativity independent of therapy, that the value of being MRD negative may be the same, and just doing it within one trial would not be possible to study those things. So that's the reason why I'm interested in looking outside trials also, to see how the standard treatments actually behave in this context. But this is just a decision we have made internally here at Memorial. What do you think?
We had an earlier discussion as a regulatory endpoint. When I was positive, you all gave me the criticism about that the flow cytometry and the methodology is not ready. Then we come to a regular practice of a patient, suddenly you're all pro for it. I just can't understand it. I still have to say, for a regular management of a patient, who's in complete remission, I don't think we have to implement that, because the methodology is standardized, is not out there. Correct. So the physician can't access it in general.
Correct.
And within our own institution, there is a lot of resource required to do it. At the end of it, you're not going to change at the bedside management of a patient other than throwing in one more, and then you yourself don't know how to counsel, because somebody who are MRD positive could stay in that way for a long period of time. But I do agree on clinical trial setting it is important, because it is conceivable with immunomodulatory mechanism or this new checkpoint inhibitor and monoclonal antibody and immune cellular therapy, and monoclonal antibodies are coming, elotuzumab. They may be able to eradicate the so-called MRD positive converting into MRD negative. So from that point of view, for a clinical trial, I agree, but routine practice, I think it is not prime time at all.
Just another point. Right now, I think we all agree flow cytometry is a kind of standard to test MRD, but maybe future research or current research in terms of next generation sequencing will show that this method is much easier. And maybe in 1 year we have data that peripheral blood MRD testing, it's much more convenient. So I think it's our job first in academic centers and in clinical trial to find out what is the best and most feasible method, and then go to kind of the daily practice and to the standard of care and recommend, do this, use this method, and it has a kind of outcome for the patient. So again, I'm not so sure whether flow cytometry is really the last word on testing MRD.
I agree with that. And I think during the discussion we had with different technology platforms, even the strongest proponents of flow-based assays said that they think that next-generation sequencing is going to be the winner. I heard them saying that, all of them.
Yeah.
Did you do that too?
Yeah.
Do you agree?
Yeah,
I think everybody said that. That was interesting. All right, so let's look at, let's watch the last movie, which is, should all myeloma clinical trials include MRD testing?
Good question. Which MRD tests should we use? So I'd like to say yes, but a qualified yes in that we need to look at what type. So we should be comparing molecular, flow, radiographic testing, and then see how well these pan out with especially new drug development. Because I have a feeling with current drugs, it's not quite ready for long-term use, but I think we need to do this for all clinical trials so we can better understand response to new treatments.
Absolutely yes. In all patients at diagnosis transplant eligible. Maybe yes in 80% of the studies, newly diagnosed elderly patient not transplant eligible. Probably not in relapse refractory patient and related trials.
All clinical trials do not require MRD testing. Maybe for selected drug approval studies, we can use MRD testing as a surrogate marker to get an endpoint sooner, such as an accelerated approval of a very exciting drug. But all other clinical trials, they do not require MRD testing.
It's clear that MRD testing really delivers so much more information than standard follow-up that all new trials should include MRD testing. That would be both upfront and in the kind of relapse refractory setting. So it's really important technology.
Again, we heard different opinions here. So you already answered on the movie. So we can ask you again in a little bit and see if you have another answer. But I start with Suzanne now.
In clinical trials, I do not agree with Sunda, and I think we should implement MRD testing in clinical trials. And I would kind of now even go a step ahead. I would probably suggest, as far as possible, to use different methods for MRD testing, to really compare, for instance, use flow cytometry and next-generation sequencing in clinical trial, if possible, if the kind of finances allow this, in order to test which is a better method, which is a more sensitive method. I think this is also important to find out. And clinical trials give us the platform to do this. So that's why I would say yes, yes, and double yes.
Sundar.
Well, looking back, I would say that for comparison of different clinical trials now for efficacy, whether the MRD is helpful, so the cross-trial comparison is possible, and whether in these clinical trials, MRD really is able to predict as a surrogate marker for PFS will be very helpful so that we can move it with more surety, with more assurance for the regulatory point of view. So from that point of view, I do agree and change my opinion from that point of view that if most of the clinical trial. But what I implied there is some regular clinical trials where you're asking 3 drug, combination with this or that. I didn't feel like this has to become important because that actually increased the cost of your clinical trial,
right,
monitoring and things like that. But I do agree for 2 things. Number 1, it improves the cross clinical trial comparison. And number 2, it establishes whether MRD testing ends up being a good surrogate marker for PFS, so we can have accelerated approval for regulatory pathway.
I agree with that.
Just one comment. I think Antonio made a very good point to say that this is probably important for newly diagnosed patients, and we have to be careful how do we use our resources. I think MRD testing is really critical for patients, first-line treatment, newly diagnosed patients, especially younger patient transplant eligible, in which we really looking for a cure. I mean, that's ultimately our goal. I think it is less important in relapse refractory trials.
No, I disagree there.
Okay, you disagree?
Go ahead.
Yeah.
Why do you disagree?
No, the reason is, suppose we have now personalized medicine. You found out there is a mutation, like BRAF, which happens only in 5% of the cases. You know that you won't be able to do a formal clinical trial in order to prove the efficacy. But if you are able to give MEK inhibitor for a patient with BRAF, and you're able to show that particular clone disappears completely, PCR negative, even though the other clones are not suppressed, so that the patient does relapse. So you really can't show much of a PFS difference, but yet this molecule did the job of getting rid of that clone, will be very helpful in allowing this drug to be used for patients who need it. So that's why this will happen in relapse or relapse refractory setting where the RAS MAF kinase pathway is supposed to be almost up to 40%. I think you talked on that.
Yes.
So this is where these kind of personalized medicine, where drugs towards a mutation will become important.
I think my take is that we should implement it in as many clinical trials as possible. And I think when we report the trials, when we write them up, we have to be very careful and not only say MRD negative, we have to say how it was done. It was done with flow. Was it done with next generation sequencing? Was it done with molecular imaging, PET-CT? And then we have to also provide information in these publications what the sensitivity level of these technologies are. If we just say MRD negative and we look at different studies, we are comparing apples with oranges. It has to be very clear how it's done. And I also agree when you're thinking that we should have multiple platforms within the given trials, if possible.
If possible, correct.
Of course, this puts a lot of pressure on the people who fund the studies. So to do both sequencing and imaging and flow is very expensive. But I think for right now, we don't really know which is the winner. So I think, unfortunately, we need to spend some more time figuring that out.
But when we plan clinical trials, for instance, how many patients go into complete remission? And if you really dedicate the number of patients and test MRD in patients who are in a complete or VGPR, I think that we have a number that is acceptable to test for flow cytometry and next generation sequencing.
In this regard, I got to tell you, you made a good debate and excellent symposium where you asked actually the industry partners for molecular as well as the academic centers who were doing the Euroflow and other flow cytometry from Europe and others to come for the discussion. And what I heard in that discussion and after the presentation when they had their own discussion, it was clear that they said whether you do molecular or by flow, there is a linear association between them, that they are collaborating. So 10 to the 5 was something that was thrown. 10 to the minus 3, 10 to the minus 2 may not be adequate, but we don't also have to go to 10 to the 6 and 10 to the minus 7. But it felt like 10 to the minus 5. But whether you do it by flow or with molecular technique, I think they all kind of left it that both are equivalent. What is your take on that, since you have tried it?
I agree. So I heard the companies, the drug companies that were here, they agree with that, and even the FDA agreed. And I think we are pretty much in agreement across the board that the technologies doesn't really matter, it's the sensitivity.
So then you don't have to do more than one method in each clinical trial?
Well, the thing is that it seems that the molecular technologies can deliver even more sensitive results. They're more sensitive, and maybe the outcomes are better if you go deeper. I think some emerging data indicates that the molecular testing is better than the flow cytometry testing. But this is an area where we probably need a little bit more workup. So then we have to pick the winner. That would be my take on that.
I thought the question is so that it is, like a regulatory agency, FDA is not going to tell you which method to use, and that was made very clear. That's not their prerogative. But what I thought was, we don't care which method as long as we agree on the depth.
Right.
If 10 to the minus 5 could be accomplished by your MFC, multi-parametric flow, or you do it with sequencing or DNA, does it matter?
I agree. So I think my take is 10 to minus 5, both flow and sequencing can deliver that. But sequencing can probably go to 10 to minus 6. So if you...
But they didn't want you to change the goalpost.
Who didn't?
People didn't want. They wanted an agreement.
They wanted agreement.
They wanted that uniformly all trials.
So maybe we have to stick to 10 to minus 5 if we're going to include flow, because flow is going to be challenged if you go deeper than that. Okay. Yeah. So this is an area where we probably need to discuss a little bit more. I think it's time for us to wrap up. So I would like to thank you.
We have a question from our live audience.
Oh, we have a question from the live audience coming in here.
Luciano asks, what about MRD to guide duration of maintenance therapy?
So we have a question from the audience. What about MRD to guide treatment for patients? So, Suzanne, do you want to take that question?
Yeah, again, so far it's an individual decision of the doctor who is treating the patients. From my own practice, if I really would like to bring the patient into a deep, deep, complete remission, and the patient is tolerating the treatment very well, and there's still, I would say, option of success for the treatment, I probably would treat the patients until MRD negativity. But there are many ifs. You know, how does a patient tolerate the treatment? Toxicity, is there still response? But in selected cases, kind of, you know, on an individual decision, I would probably use MRD as a guidance, you know, for the length of treatment.
Sundar?
You know, that's an excellent question. Those are the kind of question which needs to be answered. As I, you know, I indicated before, when we look at complete remission, it is not achieving complete remission right after transplant that's important in terms of 10-year survival. It's the durability, sustained complete remission, minimum of 3 years is important. I'm pretty sure that kind of answer will also come with MRD. So I'm in no position to recommend that if you are MRD negative when you're on maintenance, you can stop the maintenance, because I do not know, because every clinical trial with the lenalidomide, for instance, as a maintenance drug, whenever you withdraw, the patient tend to relapse. You know, all the clinical trials show that if you had one arm where it is continued indefinitely, another arm, you stop at a fixed time, then the arm which had a fixed time, then they tend to relapse quickly. So I don't think I can really, this is an area of investigation, but I really can't make a recommendation.
So I think
But the MRD positivity, I would say, is another expression of depth of response. So probably the MRD positivity tells you earlier when the patient is about to relapse.
So if you go from MRD negative to positive, that seems to precede a progression that could come 6 to 12 months later. That's what Antonio showed in his data.
Right.
But I think we are all in agreement that this is an area where we need more studies. So it's very hard to guide on this webcast how to do it. We have to look at individual patients. It has to be a discussion between the doctor and the patient, because the biology of the disease and the side effects and the patient's overall status need to be factored in.
Absolutely.
Plus that there is a lot of missing information that we need to generate from research.
Correct.
That was very important that you mentioned. It's good because they showed even among the patients who were MRD negative, those who had good risk, they did much better. Those who had high risk, they tend to relapse sooner, even though both were MRD negative. You know, that's the Pavia study which everybody repeatedly showed. So MRD negativity goes so far, but there are other biological things which plays an important role.
But that's why we recommend this to do it in clinical trials, not on the daily standard.
So again, I make a new attempt here. I would like to thank you both for coming. Thank you so much, Susanne, and thank you so much, Sundar, and thank you very much for listening to this webcast. And I think we have had a wonderful day with a lot of discussion, and I think we have made a lot of progress. I think MRD for sure is here to stay in multiple myeloma, and hopefully it will become a regulatory endpoint for drug approval. Thank you very much.
Thank you for having us.
Thank you.